Welcome, VJSocialites from EHA, joined by a really nice mix of myeloma and MPN experts and Twitter aficionados. I'd like to hand over to Ruben, who is going to pilot our first session. And Ruben, over to you. Introduce yourself and find out what's hot in myeloma and MPNs.
Well, wonderful. Well, thank you very much, Charlie. I'm sitting here lamenting, I'm sure, as we all are, that we're not able to celebrate EHA in person at the lovely Vienna. I'm mindful as I'm watching the Euro Cup, how these two events frequently coincide, and all of the exciting passions that we see on the football pitch sometimes kind of match the passion we see in the various Congress halls as we're seeing the exciting updates across the hematologic diseases, and particularly in myeloma and MPNs for this one. So let me introduce the co-chair for this session, and maybe have him introduce himself, as well as share some of the things that are exciting him about myeloma at EHA. Mohammed.
Yeah, thank you very much, Ruben, for the kind introduction. Obviously, it would have been really great to be all together in person, because EHA is definitely one of the greatest events of the year in hematology. However, thanks to these lovely virtual technologies, thanks to VJSocial, this wonderful new initiative, we are still able to be together, although virtually. And actually today, you are absolutely right, Ruben. It has been really a very good day for multiple myeloma. And I guess, although this is not the topic I'm following frequently for MPN, but definitely if we translate this into a sort of a French wine jargon, I would say it's a good bon cru, good wine. So I don't know how you want to structure this, but I can just throw in, all of these great studies that are being presented, have been presented or updated.
Well, wonderful. Well, why don't we introduce the rest of our wonderful panel before we get too much into the meat. Perhaps Meryl, please.
I'm more a myeloma person, so so my perspective from the EHA is more from the myeloma perspective. And if you're willing to hear what I'm going to say, this topic, I'm ready. But regarding MPN, I'm not an MPN person, so I don't want to be.
Oh no. No, my apologies. Why don't we have the panel introduce themselves, and then we'll delve a bit into the topics. Okay. So, Meryl, perhaps just a brief introduction.
Okay, so my name is Meral Beksaç. I'm based in Ankara University, and I'm a hematologist, adult hematologist, and doing stem cell transplant as well.
Wonderful. Tanya?
Hi, I'm Tanya J, and I'm assistant professor at Johns Hopkins, and my area of academic interest is also myeloproliferative neoplasms and cellular therapy, trying to bring those together, and a former mentee of Ruben Mesa, actually a current mentee of Ruben Mesa. Once a mentee,
wonderful.
Is a mentee.
Wonderful. And last but not least, Bruno. You're on mute, Bruno.
Good afternoon. It is great to see you all. I'm Bruno J from the University of Navarra in Pamplona, Spain, director of flow cytometry here. And I'm definitely not an MPN person, only myeloma.
Wonderful, wonderful.
But Bruno, Ruben, the myeloma community likes everybody. We are very open-minded, and we love everybody.
That we do.
It is a wonderful community. Having spent many years at Mayo, of course, where myeloma is near and dear to everyone's heart. Everyone at Mayo has a soft spot for myeloma. So one of the wonderful opportunities of being able to interact by social media like this is that we're able to gather from around the world. One of the limitations is we're pulled in a bunch of different directions. So first, and whose tight is most tight, is Bruno. So Bruno, why don't you kick us off with some of the things that excite you regarding myeloma at EHA?
Well, in sake of time, I'll be very brief, and also to let the real experts talk about what they feel about EHA. But my perspective, and again, narrowed to myeloma, is being truly impressed by the speed of development and discovery we are seeing meeting after meeting, and EHA was no exception. Just a few glimpses, we have seen data from Professor Loniel on the 4th generation of IMiDs, or nowadays cell modes, interesting data. Daratumumab already being investigated, not only newly diagnosed, but specifically in the maintenance setting. The Cassiopeia data presented by Philippe Moreau, very interesting. And this has translated also, these advances in therapy have translated also into what we do in the laboratory. A few years ago, we were talking about negative MRD rates. Nowadays, we are more and more focused on sustained MRD negativity, which is much more important. We are, because of all the new therapeutic possibilities, we are investigating more and more about new diagnostic biomarkers, thinking on precision medicine, and circulating tumor cells is looking very, very strong in the last few meetings. And despite the fact that bispecific CAR T cells are the new drugs in the block, we are already seeing very interesting data about modes of resistance to these immunotherapies. And this was shown by Leo Rush from University of Würzburg. So this would be my take about myeloma at EHA. Impressive speed of development and discovery in all areas of research.
Yeah, absolutely.
Wonderful.
Bruno. And I would simply add that I would fully agree with what Bruno said. MRD now in myeloma is becoming really a sort of pillar or cornerstone of everything we are doing in all clinical development. And this is good news because actually this is now trying to catch up with what we already know in ALL, in lymphoma. You know, when we do a PET scan after 2 cycles of chemo in lymphoma, this is about evaluating MRD and chemosensitivity. But also this is the case for CLL, this is the case for AML, and so on. So this is definitely good news. So just to bring the topic a little bit further, one of the highlights of this EHA meeting, and I would love to hear the thoughts of the group, was about the Maya trial, you know, and the overall survival advantage that we have seen for the first time with the daratumumab, lenalidomide, dexamethasone combination in the elderly non-transplant eligible patient. And I would love to hear from Miral and you, Bruno, how is MRD contributing to this result? Because roughly 29% of the patients are achieving deep MRD negativity. So how do you feel about this? Is this something where you would consider that definitely having roughly 1/3 of the patient being MRD negative is driving these long-term results?
Perhaps I can start and then I'll leave the floor to Meryl, and unfortunately you will apologize me, but I have to leave. But I would say yes, and I would say even that it's almost like the job is done in terms of non-transplant candidates. If we consider that with induction therapy in the younger transplant eligible, you may achieve around 30% of MRD negative rates. And that is what you are achieving nowadays with treatment for the elderly non-transplant eligible. The only missing point is high-dose chemotherapy that is able to induce some more MRD negative rates. But nevertheless, these are outstanding results, and I believe there is a true association between deep responses and the long-term outcome, including OS in the Maya.
Miral?
Yeah, I agree. I mean, this is extraordinary result. However, I think that for elderly patients that there is better treatments. I mean, we can improve their RD and also increase the MRD rate. But there's another perspective for the elderly myeloma. During the COMI meeting, there was a very beautiful discussion brought forward by Keith Stewart and among the biology. And I take it from their discussion that elderly myeloma behaves very different than the young myeloma. And due to that nature, MRD in the elderly may be as good as the MRD, which is higher in the younger patients. So this is another view. I think this needs to be tested for some elderly myeloma. We can be content with low MRD and they can survive long because their biology is different.
Thank you, Meral. Ruben, you are, and Tanya, you are, like I would say, external observers. Now, when I tell you that in a 75-year-old gentleman with multiple myeloma, we are able to achieve a median progression-free survival of 5 years, what would be your reaction?
Well, I could say as a non-myeloma person, certainly watching from the periphery, the progress has been extraordinary. And certainly as I've had patients along the years that I've found myeloma and referred to the colleagues, the prolongation of survival, the specificity of the agents is really extraordinary. The, great work that's been done in better prognosticating. I mean, I always had the sense that it was a very heterogeneous disorder that you guys have, I think, been able to drill down to a very significant degree. And really excited by what I'm seeing. I'll be curious to get your guys' thoughts whether with all these therapies that are evolving, whether the role of autologous transplant continues to kind of shift in your guys' paradigm. But let me punt it over to Tanya, who's also our transplant.
Thanks, Ruben. I think Mohammed can speak a lot about the transplant with his recent trial, but I think it's definitely encouraging, Mohammed, for older patients to have a PFS on an average of 5, and obviously, getting better. There are newer drugs, there are newer combinations. I think as you were alluding to the concept of MRD, you're trying to get a better, a deeper, a longer lasting remission with upfront combinations, and and most of them look like they're reasonably well tolerated even amongst older or so-called older patients. So I think the data that's coming out in myeloma is definitely like a poster child of drug development in heme malignancies so far, and it's sort of continued to be that way for now.
So Tanya, since we're talking about transplant, let me throw something about MPN. I mean, my understanding until recently, but please correct me if I'm wrong, allo transplant does it remain the only curative treatment option for myelofibrosis?
It's still the only curative treatment. It's the only potentially curative treatment, and I think it's going to be that way regardless of the drugs in the pipeline, which are tremendously encouraging. I think they're great in terms of bringing response, but I'm not sure if we have a curative signal from inhibiting any of those pathways so far, or a combination thereof.
Ruben, what are the new kids on the block?
Well, the bench is continuing to get deeper in terms of new therapies. With myelofibrosis, I would break them into a few categories. One, the other JAK inhibitors. We now have 2 approved, ruxolitinib and fedratinib. And at this year's EHA, Claire Harrison's leading an abstract that I'm one of the co-authors, looking at long-term data from fedratinib that suggests a survival advantage. And we've long have recognized that ruxolitinib has a survival advantage. So although not curative, having some impact on overall survival. And there's some very nice real-world evidence further backing that up at this year's EHA from the European experience. I'm presenting an oral abstract on the observation that transfusion independence being achieved with the JAK1, JAK2, and ACVR1 inhibitor momelotinib also has a survival advantage. So for the first time showing one reinforcing survival advantage across perhaps multiple of the JAK inhibitors if they are having a clinical impact, but two that might be tied a bit with improvement in anemia. Next, there is pacritinib that is nearing an approval for patients with marked thrombocytopenia. So there likely will be 4 JAK inhibitors. I suspect they will all become approved. And very much following in myeloma's wake in terms of evolving really from monotherapy to doublets to triplets to other approaches, I suspect patients will really have a JAK inhibitor base and then likely an additional agent. And the additional agents that are the kind of current ones out there being looked at either as monotherapy or in combination, some in front line, some in second line, include imetelstat, a telomerase inhibitor, currently in a phase 3 for in the second line setting, and a couple of drugs being looked at in the front line and second line setting, foremost amongst them the BET inhibitor from Constellation Pharmaceuticals, CPI 0610, currently in a phase 3 study, navitoclax, BCL2 inhibitor from our colleagues at AbbVie, an LSD1 inhibitor from Imago, PI3 kinase inhibitors. So the bench has gone quite a bit deeper. But we're learning a bit more about the transplant piece as well. Now, I know at ASCO, Tanya, there was some further updates and experiences related to transplant and myelofibrosis. Anything you want to share about those?
So some of the long-term data, I think, has come out in allo transplant in myelofibrosis, and Vikas Gupta and his team had presented something with regards to early versus late transplant, meaning right when you get response versus after you're losing response from ruxolitinib, and they're doing a prospective study on that as well. I think the exact timing of transplant, I agree, remains to be sort of learned a little further, and the timing of transplant and who to transplant will probably still remain a question. Also in terms of sort of the just commenting on the survival outcomes from some of these clinical trials, I think it'll be nice to see sort of the longer follow-ups, because the early stage myelofibrosis patients can the usual survival can be fairly long measured in some years. And I think it'll need some follow-up to really understand the overall survival advantage from some of these studies. But I think overall, I agree that the data looks very encouraging. I am excited to see that, we're not just focusing on the spleen anymore. We also have drugs that are now reducing fibrosis. We have drugs that are decreasing transfusion independence. We have drugs that are, reducing blast burden. We have now drugs that are potentially targeting some of the variant allele frequencies of these driver mutations. So we're able to use a lot of these strategies in decreasing a lot of the disease factors, and which may eventually translate into a meaningful survival advantage.
No, definitely. I think we are all in agreement. I mean, it's very impressive, the number of myelofibrosis cases where more and more transplanting. Actually, although I'm not an MPN guy, I was interested in the meeting with the use of navitoclax plus JAK2 inhibitors, ruxolitinib. I think there was a phase 2 study by our UK colleagues, Claire Harrison and colleagues. And interestingly, this family of drug, which is a sort of an agnostic, targeting the apoptotic pathway. And actually, we have a similar story in multiple myeloma with venetoclax. So it looks looks like, we're going to use these drugs because venetoclax is in myeloma, is in CLL, is in AML, obviously. And now we have navitoclax in MPNs. Miral, where do you see venetoclax in multiple myeloma? Or maybe at some point we need to try navitoclax, but let's see about venetoclax.
Yeah, I think venetoclax is a good drug. For some time, the Bellini study was, interrupted, but then it reinstituted. And then the new combinations of venetoclax is showing promise. And there's this ongoing trial, Canova, which compares with the pomalidomide. And there's this one, daratumab plus venetoclax combination. So, regarding a personalized based approach for myeloma, having translocation 1114 is the best candidate. So far, it's the most easiest one to detect, and we have a good target. And I think what we have seen with venetoclax is those patients, those myeloma cells which are dependent on apoptosis, even after multiple lines of therapy, they can respond to venetoclax combination and even sometimes single agent, and gives impressive results. I think
this is really impressive. And actually, while we're talking about MPNs, I must confess, I didn't attend any MPN session. However, just following through Twitter, you end up being aware of what's ongoing. Do you have the same feeling, Ruben, that with Twitter, we have such a powerful tool to capture what's ongoing, although this may not be your cup of tea?
Well, I'd say without question, so I wear two hats. I'm both an MPN specialist, but I'm the director of a cancer center. And in such, try to stay a little bit up to date on things really impacting practice kind of across multiple fields. And it's very helpful. Without question, yourself, you've been a leader in this, but many other colleagues that are really great about being able to distill down some of the key takeaways from important congresses, and particularly in this part of the year where we have both ASCO and EHA, it really is almost an explosive amount of exciting updates across multiple fields. What's really nice about Twitter is you can really get a single message out rapidly and then link it to a very specific paper abstract link, so you can always delve in more if you want. But you can really take away kind of one key audience as well. I think another key piece is, again, this sometimes helps to really expand the awareness in many parts of the world where travel to some of these meetings is sometimes more limited for a variety of reasons. I know EHA, there is a great attendance, but again, many from Latin America, Asia Pacific, sometimes the Middle East that really cannot attend some of these congresses. Now the ability to really interact, ask questions, and others is key. I have an oral abstract, and tomorrow we'll be taking, questions and answers online, and suspect those likely will be going from all over. So what sort of impact do you think it's had in improving care in myeloma?
Well, what you're bringing here, Ruben, is really something amazing, because obviously some of us are really focused on a single disease entity, but we have to acknowledge, and you have nicely alluded to all our colleagues who are doing hemoncs, across the globe. And actually the majority of the colleagues, and we should really praise them, are dealing with myeloma, lymphoma, acute leukemia. So they are struggling with all of this. And when I used to attend meetings in person, it was very frustrating for me, for instance, as a transplanter, where you need to be aware of what's ongoing in ALL, in AML, in MPNs, in myeloma, etc. And now, thanks to Twitter, I can simply just connect, to VJ Hemonc or some of the other, hashtags or links. And then you get a sort of a summary, and usually it's really very nicely done by prestigious colleagues and so on. So from that perspective, I must confess that the pandemic, this terrible COVID-19 pandemic, has allowed us actually to pave the way for a different way of education, dissemination, and spreading knowledge. I see Meral, smiling, so I guess you agree with this.
Yeah, certainly. I mean, I to add this, the podcasts. I love podcasts. When I'm driving, I have started listening to them, and it gives you the continuous input of knowledge.
Tanya, are you on the same page?
Absolutely. I think COVID has taken a lot away, but it has, if there is a reason to think of a silver lining there, I think increased dependence on Twitter and increased ability to connect with Twitter, especially during meetings. I mean, I think ASH and ASBMT, or the tandem meetings this year, attending them all exclusively virtually, I think Twitter was a big participant there. And I think if I were to think of another the trail that COVID is going to leave behind, which could be used for our advantage, is, as we were talking earlier, the televisit. So I think between sort of connecting on the social media platforms more and more, because, hey, we miss meeting colleagues, right? I mean, we used to all catch up for dinner at ASH or Tandem or ASCO, whatever. We don't do that anymore. So, Twitter is sort of our respite there. And I think it's a great medium to participate. I completely agree with Meryl. The short videos that VJ Hemonk and others create of those abstracts, those are a quick review sometimes of whether I may not be interested in the disease category as a whole, but I can do like a quick 2-minute listening and understand the overall concept of it if it's a different disease that I'm not, particularly want to know all the details about.
Yeah, it's amazing that you have top experts who analyzed, digested, and gave you sort of a quick take-home message from a paper. Ruben?
Yes, so I just have a couple moments left. I'm off to a vacation, so I'm here in an airport. But I would be remiss if didn't share a little love with a couple of our other MPN diseases. There's literally some interesting stuff at EHA. So first, in PV, we really have some exciting updates. There's a new class of drugs led by PTG 300, which are hepcidin agonists. And they are seeking to substitute for phlebotomy by kind of creating an artificial sense of anemia of chronic disease, allowing people to become less iron deficient, improve symptoms, control of hematocrit. So really might change some of the paradigm that we've long held in PV. Additionally, a lot of exciting data regarding the long-acting interferons, rho-pegylated interferon. This interferon given every couple of weeks has really some wonderful data now several years out from the pivotal studies in PV, as well as there's a global phase 3 study that Serge Verstavchik and I are leading as second-line therapy in ET. There's even more drugs on the pipeline, LSD1 inhibition, JAK inhibition, and others. So many exciting things coming up the pipeline in PV and ET as we traditionally vet most therapies in myelofibrosis, but certainly not exclusively. So a lot of exciting progress in MPNs. And with that, I will leave everyone in Mohammed's wonderful and capable hands. But Charlie, it's always been an honor to participate with this. A lot of exciting updates at EHA. And we'll put in a plug. Charlie and I work together in organizing the Texas MPN workshop, which is a free to attend global workshop in MPN at the end of August. Maybe we can put out there the registration link for folks. And last year we had 1,500 people from 40 countries. We hope that everyone who's interested in MPNs can attend.
Absolutely. And Ruben, safe flight. You're boarding now. Off you go.
Bye-bye.
Absolutely.
Thank you.
And please enjoy your vacation. You need it.
Wonderful. Good to see you, friend. Bye-bye.
And actually,
I'm use that opportunity to step out as well. I have a commitment at 1:30 Eastern time, but it was great chatting with you all and sharing our perspectives, and great to hear about all the wonderful progress, both in myeloma and in MPNs and all the other malignancies.
Well, actually, it's a true revolution in the whole hematology field, because although today our keywords were MPNs and myeloma, actually, if you dig deeper into the program, a huge progress in hemophilia, huge progress in thalassemia, a huge progress in sickle cell disease, a huge progress in thrombosis. It is a fascinating era to be in hematology, because this is like a revolution. And I'm not known to exaggerate in general, but here I'd like to share my excitement and say that hematology is now living a true revolution, and this is why we are very excited and very privileged being in this space. And here I'd like to thank you all. Thank also VJ Hemong for allowing us to have this chat. And this is, as you have noticed, a really truly live and friendly chat. Nothing has been pre-recorded. Everything was like in the real life, and this is how we love it.
Fantastic. Thank you all for joining, and we'll all see you hopefully in the next day or two for some updates. Thank you very much.
Take care.
Thanks, everyone.
Cheers.
Bye. Take care.
Bye.